somewhere in a hospital billing office, a single insurance claim is being born. It doesn't look like much. A string of procedure codes, a diagnosis code, a dollar figure typed into a form. This one is for a knee MRI. The radiology department runs the scan in about 20 minutes. The machine itself cost the hospital over $1 million to install, but the actual cost of running one scan, the electricity, the technician's time, the maintenance contract, comes out to something like $150. The bill generated for that same scan will be closer to $1,800. Not because the hospital is lying about what it costs, because the price on that bill was never really about cost in the first place. It's a number built to survive a negotiation nobody in the exam room ever sees happen, on the assumption that almost no one reading the final bill will ever ask where it came from. That gap, a few $100s of actual cost against $1,800 of billed charge, is completely normal. Hospital cost to charge data reviewed by researchers has found the average American hospital charges roughly $4.30 for every $1 it actually spends providing care. For imaging departments specifically, markups of 20 times the Medicare allowable cost are not unusual. So before this MRI claim has even left the building, it is already carrying a price built for a negotiation, not a receipt. That claim now has to travel. It gets transmitted electronically to the patient's insurer, one of billions of medical claims submitted in the United States every year. Producing and sending it wasn't free either. The industry-wide cost of just the administrative back and forth between providers and health plans runs to $83 billion a year, according to the CAQH index, the standard industry tracker for exactly this kind of overhead. Providers eat 97% of that number themselves before anyone has even decided whether this MRI gets paid for. You'd assume that on the other end, a doctor working for the insurer opens the file, reads the notes, and makes a judgment call about whether a knee MRI was medically necessary. Here's where the story turns. That almost never happens. In 2023, ProPublica obtained internal data showing that Cigna's own medical directors were using a review system called PXDX to deny claims in batches, spending an average of 1.2 seconds per case. Over a 2-month stretch, the company denied more than 300,000 claims this way. One former Cigna doctor described the process to reporters like this: "We literally click and submit. It takes all of 10 seconds to do 50 at a time. No chart, no file, just a pattern match between a procedure code and a diagnosis code, and a button." Cigna isn't alone, and it isn't even the biggest number in this story. Across the whole system, an analysis of roughly $3 trillion in medical claims submitted in a single year found that about $262 billion of that, nearly $1 in 11, gets denied on the first pass. $262 billion is larger than the annual revenue of most Fortune 500 companies, and it starts its life as the exact same kind of one-line decision made on this one knee MRI, repeated across the country millions of times a day. United Healthcare is currently facing a class action lawsuit alleging that its subsidiary used an algorithm called NH-Predict to cut off payment for rehabilitation and nursing care for elderly patients, a tool the lawsuit alleges had roughly a 90% error rate on the small number of cases that actually got appealed. 9 times out of 10, a denial got challenged. It was overturned. Now, to be clear, claims review itself is not the villain here. Insurers process an enormous volume of medical billing, and some of it genuinely is wasteful, some upcoded, some simply wrong. The industry's trade group, AHIP, calls prior authorization a vital patient safeguard. And that isn't purely spin. Federal investigators really have documented billions of dollars in fraud and billing errors every year, and somebody has to be the one saying no. The problem isn't that claims get reviewed. The problem is what happens after the no. Because here's the part of the machine almost nobody sees. What happens after a denial depends entirely on what the patient does next, and the numbers on that are almost unbelievable. On healthcare.gov marketplace plans, insurers denied about 1 in 5 in-network claims in 2023, according to KFF's analysis of federal transparency data. That's tens of millions of claims a year, with denial rates on individual plans ranging as high as 54%. Of every claim denied, fewer than 1% were ever appealed. Not 1 in 5, not 1 in 10, fewer than 1 in 100. Look at the reasons insurers actually gave on the rare occasions they gave one at all. In KFF's review of the public data, the single most common category, at 34%, was simply labeled Other. No further explanation required. Administrative reasons accounted for another 21%. 14% were excluded services. 9% came down to a missing prior authorization or referral. Only 6%, 6, were coded as a lack of medical necessity, the reason most people assume is behind almost every denial. The overwhelming majority of the time, the knee MRI isn't being denied because a reviewer decided it was the wrong call. It's being denied because a box on a form wasn't checked, or because the reason given doesn't have to be more specific than other. And when people did appeal, on marketplace plans, KFF found insurers reversed a meaningful share of the internal appeals that were actually filed. In the United Healthcare NH Predict lawsuit, the reversal rate on appealed post-acute care denials was reported at around 90%. Read those two numbers back to back. A denial that fought stood a real chance of being paid after all, and a system that counts, almost mathematically, on the fact that it won't be fought. Plaintiffs' attorneys in that case argue United Health kept using the tool specifically because barely 0.2% of policyholders would ever file an appeal at all. If a wrongly denied claim only gets caught 2 times out of 1,000, the cost of denying it wrongly rounds down to almost nothing. Federal investigators found the same pattern inside Medicare Advantage. A 2022 report from the HHS Office of Inspector General reviewed a sample of prior authorization and payment denials from the 15 largest Medicare Advantage insurers and found that 13% of denied prior authorization requests and 18% of denied payment requests actually met Medicare's own coverage rules. Under traditional Medicare, that same knee MRI would very likely have simply been paid. Here's where it gets worse, because now we can see what the incentive actually looks like from inside one of these companies, not just from the outside. A Senate Permanent Subcommittee on Investigations report released in October 2024 found that United Healthcare's denial rate for post-acute care, nursing homes, rehab stays, the exact category this whole story lives in, climbed from 8.7% in 2019 to 22.7% in 2022, the same years the company leaned harder on algorithmic review. CVS Health's own internal paperwork, cited in that same Senate report, is even more direct. When CVS rolled out a predictive denial tool for skilled nursing claims, the company initially projected it would save $10 to $15 million over 3 years. Within months, internal projections had revised that estimate up to $77 million. In 1 year alone, according to the same report, CVS saved more than $660 million in claims it didn't pay for inpatient facility care. Nobody adjusted that model because it got the medicine wrong. The number simply kept climbing because it kept working. So follow the MRI claim back. $1,800 billed. Denied may be coded as not medically necessary, maybe as a missing prior authorization, maybe simply as other, which KFF found was the single most common reason insurers gave for denying marketplace claims, ahead of any actual clinical explanation. The claim now sits with the patient, who typically has somewhere between 30 and 180 days to appeal a decision that took a computer under 2 seconds to make. Almost nobody does. And here's why that isn't really the patient's fault. Appealing a denial usually means requesting medical records, writing a formal letter, sometimes getting a treating physician to draft a separate letter of medical necessity, waiting weeks for an internal review, and if that fails, requesting an external review through a state or federal regulator. For a patient already juggling a job, a diagnosis, and a stack of other bills, that process is its own unpaid part-time job. Providers who fight the exact same claims face-to-face with insurers report spending, on average, somewhere between $44 and $57 in staff time reworking a single denied claim. And for hospitals specifically, once the appeal gets complicated, the number climbs past $100 per claim. Multiply that across the system, providers spend close to $20 billion a year just fighting claims denials, stacked on top of the $83 billion already spent processing claims in the first place. When an appeal is filed correctly, timed correctly, and completely justified, the person left holding that MRI claim is choosing between two paths, and neither one costs the insurer very much. Path 1, the hospital, having already delivered the scan, writes the $1,800 off as bad debt, folding it into a total that hospitals nationwide have reported at more than $50 billion a year, part of nearly $745 billion in uncompensated hospital care logged since the year 2000. Path 2, the patient pays it or tries to. A 2025 Commonwealth Fund survey found that among people who had a claim denied, nearly 70% said it ended up costing them more money, and 43% said the denial left them with medical debt they were still paying off. That debt joins an estimated 100 million Americans, roughly 4 in 10 adults, who currently carry some form of medical debt, totaling somewhere between $195 and $220 billion nationally. There's a third path too, and it has become common enough to have its own economy. More than 250,000 medical crowdfunding campaigns now launch every year on platforms like GoFundMe, together raising roughly $650 million annually just to cover bills insurance was supposed to handle. The results are not encouraging. Only about 12% of medical campaigns actually reach their stated goal. The average one raises around $7,000, and the median campaign, the one sitting squarely in the middle of that distribution, raises closer to $2,000. A single denied MRI claim can eat that entire median campaign and still leave a balance. Total strangers on the internet have effectively become an informal, unregulated backstop for a formal, extremely well-capitalized industry. To be fair to the insurers a second time, the rule meant to cap their profits, the Affordable Care Act's medical loss ratio requirement, actually complicates the simplest version of this story. Insurers on the individual market must spend at least 80% of premium dollars on medical claims and quality improvement, or refund the difference. Mechanically, that caps an insurer's profit as a percentage of premiums, meaning paying more claims isn't automatically bad for the bottom line, since the allowed markup rides on top of total claims paid, not against it. Absolute profit can still grow if total costs grow. Whether that rule genuinely reduces the incentive to deny claims, or simply changes which claims get denied and which get quietly approved, is a real and unresolved dispute among health economists. Not something this channel is going to pretend to settle for you. But two things sit outside that cap entirely. First, insurers who also administer large employer self-funded plans are frequently paid a flat administrative fee rather than a share of premium, which means every dollar of a claim they avoid paying goes straight back to the employer, not into a regulated margin. Second, even inside the regulated markets, a denial that's never appealed doesn't move through the system the way a paid claim does, and short-term cash flow, executive compensation, and stock performance all reward exactly that outcome. United Health Group alone reported net income of $22.4 billion in 2023. That single figure isn't proof of a conspiracy over any one MRI. It's proof that the entire machine can run precisely as designed, denial by denial, and still add up to one of the most profitable business models in the country. There has been, at least on paper, a reckoning. Congress has questioned Cigna directly about PXDX. A federal judge allowed the United Healthcare class action over NH Predict to proceed, ordering the company in 2026 to hand over records showing how the tool actually works internally. Facing mounting political pressure, the country's largest insurers publicly pledged in 2025 to streamline and reduce prior authorization requirements nationwide. By the summer of 2026, the industry's own trade group reported insurers had eliminated roughly 11% of prior authorizations under that pledge. But reporting from KFF Health News that same July found insurers quietly hedging on how much further the pledge would actually go, with critics noting the cuts had concentrated in low-cost, low-controversy services rather than the expensive treatments, cancer care, advanced imaging, post-acute rehab, where denials do the most financial damage, and where the money that CVS and United Healthcare found in that Senate report actually lives. And the strange part is, you already paid for the version of this system where that bet doesn't happen. Every month, a premium comes out of a paycheck or a bank account, priced in part to cover exactly the kind of care a knee MRI represents. The $262 billion denied industry-wide every year doesn't vanish from the economy. It just moves. Some of it becomes a hospital's bad debt. Some of it becomes a stranger's GoFundMe donation. Some of it becomes a bill in a drawer that a family will still be paying down in 3 years. And a meaningful share of it becomes the difference between an insurer's ordinary year and an exceptional one. The claim was never really a medical question by the time it reached that server. It was already an economic one, long before anyone typed in a diagnosis code. So the next time a letter arrives with the words "claim denied" printed near the top of the page, understand what actually just happened underneath it. Somewhere, a real cost was incurred: the scan, the visit, the procedure. A price was attached to it that was never really about that cost to begin with. A computer looked at the claim for about the time it takes to blink twice and said no. And the entire arrangement is quietly built on the safe assumption that you, like roughly 99 people out of 100 before you, will not fight back. If you don't, the hospital may write off part of what it's owed. The insurer keeps the rest. A stranger on the internet might cover a fraction of the gap, and whatever balance remains becomes one more line in a 100 million person medical debt file. That letter was never really about your knee or your MRI or your diagnosis. It was a 2-second BET on your exhaustion, priced by a company that ran the math across millions of ordinary claims exactly like yours and found, quietly and legally, that betting against you almost always pays off.